shortness of breath and a new cough are symptoms that most mesothelioma patients know well. They're often part of the disease having been diagnosed, and they're part of the daily reality of living with this illness. But during treatment, those same symptoms can mean something entirely different. They can signal a condition called pneumonitis, which is inflammation of the lung tissue. It's not caused by the mesothelioma, but rather by the treatment being used to fight it. Both immunotherapy and radiation therapy can cause pneumonitis, and because mesothelioma directly involves the lungs and chest, and because treatment so often includes one or both of these modalities, pneumonitis is something every mesothelioma patient and every family member helping with their care needs to understand. Today, I want to walk you through what pneumonitis is, how it differs depending on whether immunotherapy or radiation is the cause, and what treatment looks like for each. Because with pneumonitis, recognizing it early and acting on it quickly genuinely changes outcomes. I'm Terri Oppenheimer. I've been writing about mesothelioma and asbestos for the website mesothelioma.net for over a decade. I'm not a doctor, and this is not medical advice. But today, I want to make sure you have the information you need to recognize this complication and respond to it before it has a chance to become more serious. Let's start with the basics, because there's a distinction right at the beginning that matters. Pneumonitis means inflammation of the lung tissue that is functional part of the lung itself. It's from a non-infectious cause. It's different from pneumonia, which is lung inflammation caused by a pathogen, a bacteria, a virus, or a fungus. Pneumonitis has no infection involved. In the context of mesothelioma treatment, the cause is typically either immunotherapy or radiation. And while both cause lung inflammation, they do so through different mechanisms with different patterns on imaging, different typical timing after treatment, and treatment approaches that have both overlap and important distinctions. Immunotherapy-related pneumonitis develops because drugs like nivolumab, ipilimumab, and pembrolizumab work by taking the brakes off of the immune system. When the immune system is activated by these drugs, it can sometimes turn its newly unleashed energy against the lung tissue itself rather than staying focused on the tumor. Immune-related pneumonitis can develop at any point during immunotherapy treatment, but it most commonly appears within the first 3 months after starting. The presentation is variable in ways that make it particularly important to stay alert for. Some patients develop no symptoms at all. The pneumonitis is discovered only when a routine CT scan is done to monitor the mesothelioma. Others develop a dry cough and progressive shortness of breath that worsens over days to weeks. Others still present with a picture that clinical trial protocols describe as resembling severe bacterial pneumonia, fever, significant breathing difficulty, and/or falling oxygen levels. Research across patients receiving immune checkpoint inhibitors estimates the overall incidence of any grade pneumonitis at between 1.3% and 5.8%, with higher rates seen with therapies are combined like nivolumab plus ipilimumab as compared to single-agent immunotherapy. High-grade pneumonitis, which is the most severe form and which requires urgent intervention, occurs in roughly 0 to 2.6% of patients, but it carries a real risk of fatal progression if not caught and treated promptly. There's also a phenomenon called radiation recall pneumonitis that mesothelioma patients who have received both radiation and immunotherapy need to be aware of. This is a situation in which immunotherapy triggers lung inflammation in areas of the lung that were previously irradiated, sometimes weeks, months, or even years after the radiation treatment was completed. Dr. Daniel Sturman, who's Director of Pulmonary Critical Care and Sleep Medicine at NYU Langone Medical Center, and who's a board member of the Mesothelioma Applied Research Foundation, has described this as a cross-reactivity effect. The checkpoint inhibitors can unmask a pre-existing vulnerability in previously irradiated tissue, and this causes inflammatory responses in the lungs, even when no radiation is currently being given. Researchers studying the combination of immunotherapy and radiation therapy in mesothelioma have specifically flagged the potential for enhanced pulmonary toxicity when these modalities are combined. That means patients who've had both treatments deserve particular vigilance. Now, I'm going to take a break here and ask you a quick favor. If you find these videos helpful, please hit the like and subscribe buttons below. It makes it easier for other people who need this information to find us. Also, if you have questions or there's a topic you'd like to see addressed in a future video, send me a note in the comments section. And make sure you watch until the end, because I'm going to give you valuable information on where to find resources that will make a real difference for you. Now, getting back to this serious complication, radiation pneumonitis develops through a direct injury to the lung cells from the radiation energy itself. This is a completely different mechanism. It typically appears between 1 and 6 months after the completion of a course rather than during it, but after, which is something patients don't always anticipate. The affected area of lung generally corresponds to the area that received the highest radiation dose, and it creates a characteristic pattern that's visible on CT imaging, and it helps doctors distinguish radiation pneumonitis from other causes of lung inflammation. Symptoms overlap significantly with those immune-related pneumonitis: cough, shortness of breath, low-grade fever, and in more severe cases, significant breathing difficulty and falling oxygen levels. This overlap is exactly why both a careful clinical history and imaging interpretation are both necessary for making the distinction. One particularly important thing to know about radiation pneumonitis is that some patients progress from the acute inflammatory phase, which is treatable, to a chronic process called pulmonary fibrosis, where the inflamed tissue permanently stiffens and scars. Doctors treating mesothelioma patients have specifically noted that scarring can occur even when pneumonitis is recognized and treated promptly, that fibrosis differs fundamentally from active inflammation, and critically, that fibrosis can't be treated with steroids. In fact, administering steroids to patients with fibrotic lungs could potentially cause harm. This distinction matters because it changes the entire treatment and management approach once fibrosis has developed. Treatment for both types of pneumonitis follows a severity-based approach. For truly mild cases discovered incidentally on imaging with no meaningful symptoms, careful monitoring may be sufficient. For symptomatic or moderate pneumonitis, the standard approach involves temporarily withholding the immunotherapy, if that's what's causing it, and beginning corticosteroids. Standard dosing is typically prednisone at 40 to 60 milligrams daily for radiation pneumonitis and 1 to 2 milligrams per kilogram per day for immune-related pneumonitis, with a gradual taper over several weeks as your symptoms respond. For severe pneumonitis, which is characterized by significant breathing difficulty, falling oxygen saturation, and extensive lung involvement seen on imaging, the management picture includes hospitalization, intravenous high-dose steroids, supplemental oxygen, and potentially additional immunosuppressive agents. Cases that don't respond to steroids after 48 to 72 hours, which is referred to as steroid refractory cases, may require escalation to stronger medications or intravenous immunoglobulin, which is consistent with guidelines for managing refractory immune-related adverse events. Severe immunotherapy-related pneumonitis typically requires permanent discontinuation of the immunotherapy drugs involved. The bottom line, and I want to say this as clearly as I can, is this. If you're receiving immunotherapy or radiation therapy for mesothelioma, and you notice any new cough, any worsening of shortness of breath, Any change in how your breathing feels, even a subtle change, you need to report it to your oncology team without delay. Do not assume it's disease progression. Don't assume it's a cold, and don't wait to see if it gets better on its own. Pneumonitis is treatable, but the difference between a good outcome and a poor one often comes down to how quickly the condition is identified and managed. To review, pneumonitis is inflammation of the lung tissue that's caused by immunotherapy or radiation rather than by an infection. Immunotherapy-related pneumonitis can occur anywhere in the lung and can develop at any point during treatment, while radiation pneumonitis typically appears months after treatment in the area that received radiation. Both types require prompt evaluation, but moderate to severe cases are likely to require corticosteroid treatment. Any new or worsening respiratory symptoms that appear during mesothelioma treatment deserve immediate medical attention. You can visit mesothelioma.net for resources on immunotherapy and radiation therapy treatments for mesothelioma, as well as for managing treatment-related complications. You can call 1-800-692-8608 or use the live chat feature on the website to speak to one of our helpful patient advocates right away. As for me, remember to post your questions below, and I'll see you next time.